Hi everyone, good evening. I'm delighted to welcome you to our 7th Pathology Careers webinar, this time with a focus on immunology. My name's Megan, I'm the Member Engagement Administrator at the Royal College of Pathologists. So shortly I'll be handing over to Zainab and Rosie, who are our hosts for the webinar this evening. But first, I wanted to give you all a bit of an introduction to the Royal College of Pathologists, who we are and what we do. So, the Royal College of Pathologists, or RCPath for short, we are a professional membership organisation with a charitable status. So we have over 12,000 members working across 17 pathology specialties. So most of our members are pathologists and scientists working in the UK, though we also have a lot of international members working and training in a wide range of countries. And we also have undergraduate members. So this is open to all undergraduates who are studying a relevant degree in the UK and the Republic of Ireland. And membership gives you access to discounts, college publications, and science communication training. We also run a foundation fellowship scheme open to the foundation doctors. So there are some great opportunities for you to get involved with the college at this stage. So if you want to find out more, please take a look at our website or you can get in touch with us directly. In terms of the role of the college, we oversee training, exams, and professional standards across the pathology specialties. So this involves updating and running the exams, as well as producing professional and clinical guidelines for all pathologists to follow. We also do a variety of activities to make the public aware of pathology and how important it is to healthcare, as well as inspiring the next generation of doctors and scientists to pursue a career in pathology. So with that, I'm delighted to welcome you to our 7th Pathology Careers webinar. Our undergraduate medics, Rosie and Zainab, they've been involved since the start of the series, and they'll now introduce our 3 excellent immunology speakers. So over to you, Zainab and Rosie.
Hello, everybody. Welcome. It's so nice to see so many of you. I'm Dr. Boulton, and I am a trainee. So I'm here to give you the training insight into a career in immunology, clinical and laboratory, allergy, clinical and laboratory immunology, which is a bit of a mouthful. So we call it ACLI for short. I'm going to spend about 15 minutes. Please do keep me to time. Just talking briefly about what is immunology. I'm going to tell you a little bit about my journey into immunology, a bit about my current day-to-day life, some research I've been involved with, and just a brief point about the wide contribution of immunology at the moment. So, what is immunology? That's a very good question, although hopefully as you're here, you already had a bit of an idea. But in brief, immunology is a clinical specialty, and we focus primarily on issues affecting the immune system. We also look after a lot of patients with allergies, and we're also heavily involved in laboratory immunology. So I'll explain a bit more about what all of that is in a moment. One of the key questions I'm often asked by people interested in immunology is how do you get into it? So from a training perspective, I'm going to tell you a bit more about what is immunology. So I've taken this from one of the JRC PTB or Federation of Medical Specialties curriculum documents. So this is to give you an idea of what immunology is from a training perspective. You may be familiar with this already, so I'll try and keep it brief. But in general, there is a good chunk of training that you need to do before you can apply to immunology or allergy. You can see here you need to do the foundation training first, and then you'll need to do core training of some form. A lot of people come through internal medical training or IMT, and you'll be pleased to know that immunology and allergy are both Group 2 specialties, so you only need to do the first 2 years of that. But you can also get to it through other routes. So, for example, you can go via ACCS, one of the STEMs, or even pediatrics too. But as you can see, either way, there's between 4 to 5 years of foundation and then core training first. And then you would apply to the streams at what we call ST3 or Specialty Training 3 level. And here you can see there's a split. So before 2021, there used to be immunology training and allergy training. And since 2021, things have changed quite a lot. And the RCPath was involved in those curricular changes. So hopefully you can see there are two streams, as I say. So there is a longer one of 5 years, which is what used to be immunology and is what is now called Allergy, Clinical and Laboratory Immunology, or ACLI. The key difference here is obviously it's longer, but there's more of an emphasis on laboratory immunology training as well, hence that extra year. This is different to ACI, or what used to be allergy training. Allergy training is shorter, although since 2021, there is also now an emphasis on laboratory immunology, but as you can imagine, it's less because one, there's less time to do it, and also actually the emphasis is more on allergy and less so on the clinical immunology and lab immunology. But of course, it's still there. So just to let you know that those two pathways exist. And just super briefly, I'm sure you're familiar that in terms of once you get through medical school, sadly, that's not quite the end of exams. You do still have to do postgraduate exams too, which, yeah, take a bit more planning, I would say. But again, there are slight differences in terms of the 5-year ACLI stream versus the 4-year ACI stream. So essentially, the longer one has to do more exams, and the shorter one only has to do one exam, assuming you've finished your core exams already. Yep, that's it in a nutshell. And I'm sure we've got lots of time for questions later. So I'm sure you'll probably want to find out a bit more about that, but we can do that in the question time. Okay. Moving on to my journey into immunology, and I've picked this image because it represents my slightly convoluted route into it. I think things are different now compared to even, I think it was what, 10 years ago that I was thinking about this, and people are much more aware of it, but I actually wasn't so aware of immunology at the time. So I will tell you how I got here. So for undergraduate training, so I studied at the University of Cambridge, which at the time was a very traditional course, sort of preclinical years to start with. And then I intercalated and did a BA, and it was in pathology. And actually, I picked to do, it was in kind of two chunks. I picked to do immunology, and there was quite a lot of microbiology as part of that too. And also got to do a lab project with the virology school, looking to norovirus, which was very interesting. And at the time, I loved it. But I thought, oh, that's great, but that's kind of the end of that because it was very interesting, but it's very, very scientific. So I'm not really sure that's going to carry forward into the rest of my career. And we will see how that changed later. So then carrying on with undergraduate training, stayed at Cambridge for my clinical years and got to do some student-selected components. I wasn't really sure what I wanted to do. I thought I wanted to do something a little different, not sort of pure medicine, not pure surgery, that kind of thing. So initially I thought about radiology and I didn't love it. And then I thought oncology would be good. So I did an elective in it, was with the breast cancer team. I had involved in some phase 1 clinical trials, which again, I thought was super interesting. And I thought, great, this is it. It's got all the things I want. It's on the cutting edge. It's quite academic, but a bit more flexible. There's a potential to make a real difference. So let's try it. So I did. So fast forward to postgraduate training. So F1 and 2, I stayed in East Anglia. Was lucky enough to get a rotation in hematology, which again, I thought was fascinating, if not quite busy. But I really enjoyed getting to see bone marrow transplants happening, even though, of course, for the patients, it's very stressful and a very tricky time. But the kind of immune changes behind it, I thought were fascinating. So, but it did also teach me that I didn't want to be a hematologist, sadly. And then for core training, I moved house, relocated to South London and spent most of my time at St George's. And where I was lucky enough to do a rotation in oncology, what I'd waited for a long time. And sadly, I did not love it. So that threw a big spanner in the works because I'd obviously picked my rotations based on that job. So I suddenly had to do a bit of rethink. But I went through the rest of my rotations as planned, and again had another hematology job, got a slightly different experience in South London compared to East Anglia, which again was really interesting. Got a job with some dermatology experience, and actually I was involved in a psoriasis clinic where they were using biological agents, which again was a great experience. And also very involved in neurology, had a neurology placement rather, where I got to see again some biologic therapies, and a couple of cases of autoimmune encephalitis, which I understand is quite rare. And again, found them all very interesting. But now I had this quandary. I didn't want to do oncology anymore, so what did I want to do? So at that point, I took a career break. I finished my CMT training at the time and got a job as an education fellow at West Middlesex Hospital because alongside this, medical education has been something that I've always found very interesting as well. So I thought I'll take a bit of a break, do a slightly different job, get some different experience and build my CV. And I reflected. I thought, what was it about oncology that made me think maybe that was it? And as I've mentioned, it was the academic aspect, the ability to kind of subspecialize, become maybe an expert in something one day, but importantly, to make a difference. But a key thing I'd learned from the oncology job was I didn't like looking after acutely unwell patients, which I perhaps could have seen before then. But anyway, it was a good lesson to have learned. And I also realized that on-calls are quite tricky, and I was already finding them quite tiring. So a job where I had to do less of that would also be amazing. So I did an online questionnaire. I'm not sure how robust those are, but it gave me a list of slightly random, but mostly outpatient-based specialties to think about. And on the list was immunology and also allergy. And then things kind of clicked. I thought, well, why didn't I think about immunology before? I really enjoyed my interpolation, etc., etc. So arranged some tasters, really enjoyed them. Got in touch with one of the consultants that had kindly hosted me for one of the tasters, and we did a project together, just a little audit. But it was accepted at the BSACI conference that year, so I got to present it as a poster, and I also got a scholarship. And at the conference, I got to meet people who I thought were actually quite like-minded, similar sort of interests. The lectures that we had were super interesting, both allergy and immunology focused ones. So I thought, great, let's go for this. I'm very happy to say that I applied for training and got a job. And as I say, the rest is history. But just an important thing to say, it's not all about work. So I did also try and squeeze some fun in, and I do quite enjoy singing and musical theatre and stuff. So here's some times when I managed to do a bit of that too. Okay, moving on to day-to-day life. Check how much time I've got. I'm going to speed up a little bit. So as I mentioned, for ACLI, the kind of three main components are allergy, clinical immunology, and lab immunology. So a typical week for me will look a bit like this. All of the specialties, or all of those, fall under largely outpatient bracket, the outpatient bracket rather than inpatient bracket. So personally, I spend the vast majority of my time in clinic looking after outpatients. Where I train, we do have a system where inpatients can have immunology consultations as they need to. And when our patients are admitted, obviously, we're involved in their care. But the way our trust works is that we're not sort of the primary team looking after them. So it's much, much more outpatient, which kind of suits my need for a bit more of a work-life balance. And as a result of that, I spend a lot of time in clinics. We have lots of MDTs, including cross-specialty ones, so particularly working closely with respiratory and infectious diseases, but of course other specialties too. And then, as I say, at the moment, so I'm just over halfway through my training and gearing up for some of those later exams, which are much more lab focused. So now my training has been tailored, so I'm spending about a day and a half of the week in the lab every week, which has been really great for bolstering my lab expertise. But on the note of kind of tailoring, you can also arrange attachments in different relevant specialties, things like pediatrics, vasculitis, those kinds of things. And then threaded through all of this will be teaching. So, for example, we have teaching twice a week. There's lots of opportunities for research, which we'll all talk about in but of course, you do have to think about revision and examinations at points, because there are those extra examinations that perhaps other specialties don't have, although a lot of the path specialties do have. So, actually, a bit more about what this means. So, from an immunology point of view, the kind of patients that we look after, we tend to look after on the medium to long term. We predominantly look after adults, although there are pediatric requirements on our curricula. So we do need to do a little bit of that and have an awareness of the conditions that present early in life. But the majority of our time is spent looking after adults. In this cohort, that means that at least in my experience, a majority of the cases that are referred to us are patients who have hypogammaglobulinemia, so low antibodies. And part of our role is to work them up, find out what's happening, and largely, or at least as part of that, figure out whether it's something that's primary, so something that's inherited and that they've actually had potentially their whole lives, or something that's secondary, so is a result of something that they've been treated with or as a condition that they've had. And the kinds of primary immunodeficiencies that we see, so by and large, at least again in my experience, the majority of cases will be people with common variable immunodeficiency, so CVID, which is largely an antibody deficiency. We do see some of the other cases, so for example, I've listed some other ones on there, but the kinds of patients that you see will actually vary depending on where you are in the country to a degree. So for example, London has an entire CGD clinic, so that's a phagocyte defect clinic. And other places will have other pockets and different clinics. So your experience does vary a little bit depending on where you train. Another condition that we see a lot of in immunology clinic is something called hereditary angioedema, which is characterized by swelling, and it's not mediated by histamine, it's mediated by the bradykinin pathway. So again, these are patients with a long-term chronic condition that we spend a long time looking after and making sure that we are optimizing their health and avoiding long-term complications. In particular, complications from recurrent infections, things like bronchiectasis and other structural diseases that will, shorten their lifespans if we're not aggressive and proactive about it. So that's immunology in a nutshell from my perspective. In terms of allergy, even though it's obviously very immunological, it's kind of the opposite end of the spectrum. So the patients we see in allergy tend to be day case or very short-term follow-up. We don't tend to have long-term cases apart from in one condition, which I'll mention in a second. The kinds of conditions we see would be food allergies. We're really lucky to have a very big drug allergy clinic here. We do a lot of insect venom clinics and also see patients with allergic rhinitis and asthma. But we also see a lot of patients with chronic spontaneous urticaria and angioedema. So they're another kind of potentially longer term case that we will follow up. And the kinds of things that we do will be obviously investigating, so things like skin testing, blood testing to make the diagnosis. But we can also offer interventional things like provocation testing, especially in food and drug, to kind of clinch the diagnosis and make sure that things are okay to eat or consume. But increasingly, there are immunotherapies on offer. So venom, pollens are quite well established, but there's increasing access to peanut immunotherapy, which is fantastic. And I'm sure other food immunotherapies will be coming down the pipeline soon. And most excitingly, perhaps, or at least for me, things like monoclonal therapy, so things like omalizumab, in the context of chronic spontaneous urticaria and angioedema, and other things as well. And then finally, the lab. So this was the biggest kind of blind spot for me, and it was perhaps the biggest reason I was a little bit unsure about going into immunology in the first place, because certainly I didn't have any notion of what that really meant, especially not as an undergraduate. So to hopefully make it a bit clearer, your lab experience will again be a little bit different depending on where you end up training, because different labs do different assays. But by and large, the roles are things like contributing to interpretive comments, validating assays or validating results. There's a lot of clinical liaison where you speak to things like people like GPs or other clinicians who either want help interpreting tests or want help, kind of further advice on further tests to do in a specific context. So that's quite interesting. It's a bit of problem solving. There's a lot of troubleshooting, both in terms of being in the lab itself. So for example, you get a slightly weird result. What do we do with this? And again, there's a lot of problem solving there, which I quite enjoy, but also kind of clinical as well. So the big thing that we bring to the table as clinicians is putting that clinical interpretation spin on things. So, the people who work in the lab day to day are very good at the technical elements, but we bring a kind of context and interpretation to it. And then finally, there's sort of more lab management roles, so things like quality control, assay development, commissioning, those kinds of things, which you can potentially get involved in as well. And the tests that we do this for, so there's ones that we would consider, well, again, this may be more effective in my experience rather than everybody's, but the tests we do this for, so there's kind of more typical immunology tests, so things like immunoglobulins, complement, we can do other things with cells, for example, lymphocyte subsets. But interestingly, we've got lots of experience in areas where you perhaps wouldn't necessarily expect an immunologist to be involved. So lots of autoantibodies, so ANA, anchors, rheumatoid factors, we do a lot of, especially here. We're primarily responsible for myeloma screening here. So we do the protein and urine electrophoresis and gel electrophoresis as well. Of course, there's the allergy assays. So things like mast cell tryptases, IgEs, specific IgEs. And then, as I mentioned, different labs do different things. So we work as a kind of network, and we'll send tests to other places nearby that can offer things that we perhaps don't. So for example, we sometimes send things to Great Ormond Street Hospital because they have the very technical complement of functional tests that they only do. And for example, Cardiff specialises in a lot of complement tests, so there's lots of additional things that they can offer that other places can't, for example. But there's just a couple of examples. Okay, penultimate chunk, a bit of research. So my research experience has, you'll probably see in a second, it's been a little bit of a hodgepodge, but I have thoroughly enjoyed everything I've been involved in. And I've been really lucky to have had experience in both clinical and medical educational research. So a little bit about what I've been up to. So when I first joined this job, within a couple of months, I had been signed up to be a sub-investigator on 2 clinical trials, which was obviously grateful, and I was very pleased that that was the case. But I didn't realize it would be so easy. So the bigger of the 2 I've put here. So I was a sub-investigator for one of the COVID vaccine trials at the time. So Ensemble 2, which went on to be the Janssen vaccine, which was a great experience. I've also been lucky enough to be involved in some publications. So for example, some colleagues and I at my centre worked on this little review on skin manifestations and inborn errors of NFP B. There's a trainee network which tries to do sort of collaborative research, and this is one of the outputs on that, on Veritralstat experiences from the UK. Myself and a colleague did a little commentary piece on anti-interleukin 4 or 13 agents in asthma. And this was the abstract that was published as a result of the BSACI poster that I did that I mentioned a while back. So that's me at the time, back in 2019. And actually, as time's gone on, I would probably say my bigger research interest is more medical education, or at least it has been for the last couple of years, I would say. At the moment, I'm completing an MSc in health professions education. I've been really lucky to have been invited to do a couple of presentations at conferences. So at the end of August, for example, I was in Switzerland at Amy, doing a workshop with some of the PGME team from Great Ormond Street. Last year at BSACI, Katie and I, who were due to be here today, sadly can't make it after all. We did an oral presentation together. Again, we've had a few things published, a couple of abstracts, and then this bigger paper on an evaluated project that we did during COVID, back when I was working in West Mid. I've also had a few prizes, which is always nice. Nice to be recognised for the effort that you put in. So yeah, but just to say, don't feel that you have to have a research interest. As you can see, mine's a bit eclectic, which is perhaps not what you might imagine for a traditional immunologist. But yeah, not everybody who does immunology has to do research, I just wanted to say. And then final chunk. So just, I'm not going to spend much time on this because I think I'm overrunning terribly. So I'm just going to say 10 seconds on this. The impact of immunology is growing. There is greater understanding of how the immune system works, thanks to greater access to next generation sequencing and genomic testing. So we are understanding in much better detail how the immune system works and also how it doesn't. And this means that we can offer much more tailored and person-specific therapies. So I just wanted to briefly introduce you, if you weren't already familiar with gene therapy. So gene therapy is not new, but in immunology, it's been making waves and is a very exciting prospect to be able to offer in the next few years. But given that a lot of not all, but there are a significant number of primary immunodeficiencies that are monogenic. And previously, the only treatment we could really offer was bone marrow transplants, which have, they're risky. Not everyone can have them. Not everyone is well enough to have them. Not everyone gets a donor. And having gone through such ablative chemotherapy, etc., increasingly the issue isn't can we do it? It's how do we manage the sequelae? How do we manage the hypogammaglobulinemia that we've given them as a result? So it's about managing comorbidities. The gene therapy is super exciting because if we can give back that gene that's not working, we could, completely change their life, and with comparatively less chemotherapy as well, so less long-term downstream effects. So it's a very exciting area, and I recommend you all have a read. And that is all I'm going to say. Sorry for overrunning. I've put a slide on questions here. I know we're going to have a Q&A, so have a think if you've got any questions, make a note, and then I will happily answer them when we come to the Q&A section. And these are my details if you're interested, and I'm very happy for people to email me.
Thank you, Anne. That was really interesting. Again, if anyone has any questions to answer in the Q&A, please put them in the Q&A section. And if it's for a particular speaker, just make sure to put their name there as well. So when we read it out, we know. Okay, moving on. Our next speaker is Professor Mohammed Yousuf Karim.
Right, thank you. Thank you for the invitation. There will be a little bit of overlap with the first talk. I'm going to talk about my personal journey, a little bit about how immunology contributes to medicine, my day-to-day work, and a little bit about my current research. And of course, I've got a completely different perspective because I've been a consultant for 20 years. So we're going from a trainee to a kind of long in the tooth consultant. So it'll be a bit of a different picture. So again, slightly unusual pathway into immunology. I obviously also graduated from Cambridge. I did my SHO jobs in various medical specialties in London and Nottingham, did MRCP, and then actually I wanted to be a nephrologist, and I did a lot of renal. I did 2 SHO jobs in renal. I did a registrar job at the Hammersmith and Charing Cross in renal. And in a way, it was a little bit, I loved looking after acutely sick patients, but it was taking my toll on my health. I was really, in those days, it's not like now. We were doing one in 3 on calls, and you would do Friday, Saturday, Sunday, Monday. So you would regularly do 120 hours a week. So at that stage, I said, right, I'm having a break. I'm going to do a master's in immunology. So kind of a bit of a similar story. And during this year, a couple of colleagues said, well, have you thought about doing clinical immunology? And at that stage, immunology had an even lower profile than it does now. Nobody really heard of immunology. I certainly hadn't, even though I'd done a lot of immunology at med school. Never heard of it. But it turned out I was a few people I went to see. I went to see the professor at St. Thomas's, and then sounded great, actually. And so then I applied and I got this post, this combined academic clinical post. And while I was doing this post, I was interested in autoimmune disease and in nephrology. So I got lucky and I was able to continue my research on lupus nephritis, which I'd started during my master's. And I actually set up a lupus clinic alongside the rheumatologist and nephrologist. And that morphed later on into a clinic for secondary immunodeficiency. So then 2004 became an immunology consultant in Guildford and Frimley Park. So it was called Surrey Pathology Services. And I also then had a part-time position at Guy's and Tommy's running the laboratory. So at Thomas's, I ran the immunology laboratory, and I also did a lupus clinic once a week. And in Guildford, I did more allergy, general immunodeficiency, and some lab work. And then I worked in the NHS for about 25 years. And then in 2018, I actually moved to Doha, Qatar. And here, actually, my job, I'll tell you about in a minute, but it's very different, actually. It's much more lab related. And I run the immunology lab as well as hematology and transfusion. It's a combined division. And I have a much smaller clinical role in seeing patients. So this is the opposite of what I did in the UK, which was predominantly clinics and less lab. This is predominantly lab and much less clinical work facing patients. And it's a pediatric and maternity hospital. In terms of academics, I've been lucky enough to do quite a lot of teaching, both in the UK and then since I've been here in Qatar. And actually, this is something that I wasn't really aware of. And again, the reason I mention it is a little bit of doing your time. When you get promoted, it's not necessarily how good you are or how many publications, it's have you done the time. So the sooner you can get on the ladder, the better. So over the years, I sort of gradually got promoted. And it's a combination. They recognize you for your teaching and also your research and your publications. And I would say that of the three, depending on the institution, some are very, very teaching focused and others really look at the impact factor of your publications. But it's, as I said, it's been a gradual process over many years. So this is something that Anne mentioned. And basically, when I started, obviously a very, very long time ago, we didn't have next generation sequencing. And immunodeficiency, or as it's known as inborn errors of immunity, was really fairly basic, actually. Once we got NGS, the rate of discovery has been unbelievable. So, over almost a threefold increase in 15 years in the number of diagnoses. And again, when I became a consultant, you could probably name most of the immunodeficiency disorders. There's no way now I could mention more than 500 different disorders. And this has really been amazing, a transformation. And one of the other things that's come up is that we don't really talk about immunodeficiency so much as inborn errors of immunity. And that's because of this concept of immune dysregulation. So now you can have patients who are referred who have hypergammaglobulinemia or have lymphocytosis. And they not only have predisposition to infection, but they may have allergy or autoimmunity or lymphoproliferation. So it's a whole different gamut of associated disorders. And the treatments are not necessarily replacing what's missing, but actually sometimes immunomodulation and immunosuppression. So the nature of conditions that we're describing and recognizing is also different. And this is illustrated on the left is data from the UK PIN, a 5-year period. And some of this is just better data collection and better recognition. And some of it is probably genuine increase. And on the right is from the Jeffrey Modell Network. Jeffrey Modell Foundation is based in the US. It's the premier primary immunodeficiency organization that supports clinical work, it supports research, supports education in PID, named after the son, Jeffrey Modell, who died from primary immunodeficiency back in the 70s. And it's an amazing foundation. And their work has shown from their network of hospitals that pretty much most immunodeficiencies are increasing. And of course, the major one, the most common one is, of course, antibody deficiencies, which again, Anne referred to in adults. Immunology is one of the most rapidly advancing specialties. Every year we've got new treatments, new tests, new diseases even, and it covers a whole range of illnesses including allergy, autoimmunity, immune deficiency, and it's a very exciting specialty to be a part of. So I recommend immunology to anyone who's considering an academic specialty, especially with a lot of teaching and a lot of modern advances. Next slide, please. So that was a bit embarrassing, but the reason I put it in was I thought, that was 2012. Obviously, I had a lot less gray hair then, but pretty much what I said then is what I'm saying now. And sometimes I'm asked, in fact, I was at a meeting just yesterday in Dubai, and someone said, all this genetic testing, does it really make any difference? It's very expensive. We don't really always get an answer. But actually, when you do get an answer, which is actually more than 50% of the time, and if it's severe combined immunodeficiency, it's about 60% of the time you get a diagnosis from the genetic testing. It's an amazing feat because we can give the patient and the family a diagnosis. We can give them advice about prognosis. We then may be able to give tailored therapies. We may decide to go for a bone marrow transplantation or gene therapy, depending on what the defect is. And then we can counsel the family. And there may be siblings who could be affected, and we can advise them for future family planning and, for example, pre-implantation diagnosis. So this sort of advance, of course, is academically interesting, but it really does have practical benefit for our patients and for their family. So a little bit about how the advances are being achieved. So basically, as you've heard, there's been amazing advances in next generation sequencing. So we now have clinical gene panels, whole exome, and actually in my institution, we go straight to whole genome sequencing because where I'm working is very high level of consanguinity. So very high level of autosomal recessive disorders. So we go straight to whole genome. In parts of the world, there are newborn screening programs, which are amazing for picking up early diagnosis of SCID. And then there's clinical care advances and novel therapies. And there's a lot of collaboration now, both internationally and on a national basis. So really, these clinical advances and the molecular advances are coming together to improve immunological care. So a little bit about what I do. So I have a clinical role. And I'd say the reason I've asterisked that, it's basically as a consultant, that's your bread and butter, looking after the lab and looking after patients in the clinic. These other bits may come later, or you may be interested in some or not others. For example, admin roles. When I first started, I was just a pure clinician, and now I have administrative roles. Not everyone enjoys admin. Then I do research, I do some teaching, and I have some national, international roles. When I was in the UK, I was a lot of stuff in the BSACI, actually. And again, none of this is compulsory, and some of it comes about organically. People ask you to do things, and then you take them up. So a typical day, go through emails, start at 8, then there may be a business case that we need to present for a new test or a new service, Path Exec Committee. Then often we have lab consults on MDT, discussing complex cases, some routine authorizing. Still, I do that, flow cytometry, for example. And then the afternoon, immunology clinic, predominantly immunodeficiency. Then research project team catch up with the progress. And then often my research work, paper writing or grant writing, is often out of hours, to be honest. But this is a typical day. Obviously, clinical days might differ, might have more ward consults or allergy clinics on other days. So you've already heard a bit about the immunology diagnostic lab, so I won't say anything about this, but I will say that obviously in our area, part of the world, PID, immunodeficiency, is very, very common. So we have advanced flow cytometry panels, a lot of more panels than I did in my UK lab, actually, we have in our lab here. And we have a big link with research. So when our clinical testing stops, we link with research. Research can do functional testing, and then sometimes it comes back to us to validate in our lab. Again, I won't say anything about this. This is a sort of flow cytometry plot. The blue arrow, this is a patient who's on rituximab for lupus, and this is supposed to be where the CD19 B cells are, and it's absent. It's completely empty because the child has just received rituximab recently. So administrative is not for everyone. I have to run the division, and I am responsible for maintaining the accreditation of the division. Here it's College of American Pathologists. In the UK, it was CPA, it's UCAS now. I have to recruit pathologists. I'm responsible for their performance and their appraisals. And I represent the division at Pathology Executive, but also more widely in the hospital. So if anything's going well in the division, I have to liaise with other clinicians, what do they want in terms of testing. Anything goes wrong in the hospital, in our division, that's again on me. And for example, last week we had an assay problem that enabled hundreds of old results to be released to the clinicians. And so I had to deal with that and sort that out. So administrative, it's not for everyone, but as you get more senior, sometimes it does become your cup of tea. I do quite a bit of teaching. I do enjoy the teaching, both clinical, so the residents and fellows, and these are pediatric residents and fellows in different specialties. We have a clinical scientist trainee from the UK, actually. We have medical students. There are 2 affiliated medical schools here, and I'm responsible for the medical student electives in pathology. And actually, within our division of pathology, I'm in charge of education and CPD for the technologists and the pathologists. So research, again, I'm involved in a number of different research areas. This is a project that I'm leading that we've got a grant for. And basically, this is looking at children who have either juvenile idiopathic arthritis or SLE. And we're looking at high frequency in-home transcriptomics. And basically, this is monitoring. We have a novel device. This is called a home RNA kit, which comes with this basically almost painless blood collection on the upper arm, or can be done on the back or the thigh. And then this collects blood through a capillary system, and the blood's then incorporated into an RNA stabilizing tube. And the idea is to do high frequency to see if we can demonstrate changes, tipping point changes in transcriptomics in patients who are on biologics. And it's a 13-week weekly testing. The patients are trained on the first visit, and then the parents and the patient do it at home every week for 13 weeks. Obviously, if they have a flare, they come to the hospital. And then at that point, we do both the the Tasso device, and also a venipuncture. So the idea of this is to show that we can do this. It's feasible to do it in home. The patients and parents are happy, but also to generate data for transcriptomics to see how closely we can monitor their autoimmune disease. And this is another area that we're involved in. We arranged the first primary immunodysregulation disorder conference in the Gulf region, and this was just earlier in May. And we had a whole range of people. This was done in collaboration with the NIH. So we had 5 speakers from the NIH who came all the way to give us fantastic talks. And again, this is the sort of thing, it's beyond our traditional role, but again, an education initiative. I know I'm probably going to overrun, and I apologize in advance, but I have a slide at the end from the BSACI, which I must show you. So I'll just try and get to it as quick as possible. I would say opportunity in immunology. Basically, there's less acute medicine, less acute medical decisions, fewer procedures, but they're more complex cases, and you can really get your teeth into them, think about them carefully, and work them up. So it's more complex cases. You've heard about the clinical workload already. It's outpatient. What I would say is we're not really involved in autoimmunity as the primary caregiver. I have to say that I was an exception. There are a few of us who are an exception. It's getting less and less. Lupus and vasculitis is usually the remit of the rheumatologist and nephrologist. We sometimes work together with them on that. The awareness especially is still low, but much better than when I started. And it is such a rapidly advancing specialty. There's so many varied options, and I just try to show you what I'm doing, clinical, lab, academic, management, teaching. So, and you can really flex your career how you would like to, providing you get the opportunities. One thing I would say about the lab, I really like the lab. As I say, I used to do more clinical than lab, but there is a changing role. And as with all the pathology specialties, medics are coming a little bit more out of the lab, and clinical scientists are coming more into the lab. And of course, there is a session from clinical scientists. You'll hear all about that later. But there is a little bit of a shift, I would say. As I said, plenty of opportunity for research and teaching. I would say another thing, during your career, really try to think good for international opportunities. Do a fellowship abroad. Think about broadening your horizons. It really does benefit you in the long term. Bit of advice. And again, if you're thinking about career in immunology, talk to registrars, talk to consultants. They're usually very approachable. Ask if you can arrange to spend some time in immunology. Try before you buy, just like Anne said. And it may be very different from your previous jobs. As Anne said, lab is something that's totally different from your clinical experience. The other thing is, think about the long term. Yes, see what the registrar does, but actually more importantly, see what the consultant does, because you're going to be a consultant for a lot longer than being a registrar for 5 years. So really think, what does a consultant do? What is the day-to-day life of a consultant? Do I like that? That's in fact more important. So just to promote, this is really important. BSSCI, I've been involved with them for years, helping with their conferences, arranging the immunology session in their conferences. They are a fantastic organization. They've got this medical scholarship scheme to promote basically for FY2 doctors, IMT trainees, and it will cover both the conference fees and the accommodation and travel. So this is only for adult trainees, but again, this is a tremendous initiative. I think this is my penultimate slide. I am promoting immunology. I am an immunologist for the last 25 years. I would say that there are alternative approaches to immunology. For example, there are other ways to practice in immunology-related specialties. Some of my colleagues who were doing renal with me did rheumatology or renal, and they did a PhD in immunology. And when I was deciding to switch, I went and met a chap called Ken Smith, who I'm sure all of you know, he's the professor of medicine at Cambridge now. And he said to me, well, immunology is great. It's a multi-organ disease, multi-organ specialist, but ironically, you will lose your organ base. And he was absolutely right, because people refer to nephrology, they refer to rheumatology, but sometimes in immunology, it's systemic. You may not get all those vasculitis referrals. And so you then do get pigeonholed into immunodeficiency and allergy. So it's a slightly different concept. But as I say, I love doing immunology, and I would definitely recommend it to all of you. So I think that might be one more slide, or that might be it. Thank you. Yes, thank you so much. And apologies again for overrunning.
Thank you. That was very interesting. And again, just a reminder to everyone, questions to go in the Q&A, and we'll answer them shortly. So our next and final speaker is Dr. Betsy Cleave.
So I hope you can all see my screen okay. My name's Betsy Cleave and I'm the final speaker of the evening. I sit somewhere between Anne and Yousuf because I've just started as a consultant within just over the last year. So what I'm going to speak to you about is why and how did I become an immunologist? And I'm going to talk a bit about what my job looks like. And I just want to give you the caveat that this is not a talk to persuade you to become an immunologist. When I was at university, we had some careers advice where we all went into the lecture theatre and every consultant from lots of different specialties stood up and said, this is why my specialty is the best. This is why you should do my specialty. Actually, my feeling is that all specialties are important, but actually all of us as medics have different skills, different gifts, different strengths, different things that we find easy or difficult, different things we like to get our teeth into. And actually the key is to find the right specialty for you, the place where you fit and where you can use your skills and your abilities to serve your patients best. And for some people that might be surgery, for others that might be medicine, for others that might be immunology. So when you're thinking about your what specialty you want to go for, then think about your personality and your strengths in that. So what do you want to be when you grow up is basically the question that you are asked at every point throughout your medical life, from before you go to medical school until you have committed, and sometimes after that as well. And so growing up, I wasn't sure what I wanted to do, but when I was about 14, 15, I thought, I think I want to do medicine. I decided I wanted to be a paediatric surgeon. I went to a Royal College of Surgery open day and learned all about surgery there and thought, oh, that sounds amazing. That's what I want to do. Then I went off to medical school. I also studied in Cambridge. And when I started doing anatomy in my first year, I thought, oh my goodness, this is hideous. I really don't like anatomy. It's all rote learning. It's all about spatial awareness, of which I don't have the best spatial awareness of all time. I thought, there's no way I'm going to be a surgeon. Pediatric surgery is not for me. In my third year, I intercalated and I chose to do something called mechanisms of disease, which was essentially a clinical pathology. And within that, I chose to do a dissertation, and we could choose whatever we wanted to do a dissertation on. And for some reason, I found the immune system really interesting. And I came up with doing a dissertation on the role of regulatory T cells in graft versus host disease, which is a condition that can happen when you give bone marrow transplants, which are not optimally matched, or even when they are well matched, there can still be discrepancies in alleles and antigens, and that can result in this disorder. And so that's what I did my dissertation in, and really found it very interesting. I then went on to clinical school. Again, I stayed in Cambridge for my final 3 years of clinical school. And during that time, I very much realised that I was a medic, not a surgeon. And I think that's one of the helpful distinctions to make. Are you more medical? Are you more surgical? And I went off to do my elective in Durban in South Africa, and I ended up doing adult medicine, which was largely inpatients, and there was a lot of HIV medicine, which I found really interesting, but also quite a challenge and quite different. I saw quite a lot of patients who died, which was really quite tough. And by the time I came to graduate, I'd whittled down my choice to medicine, paediatrics, or being a GP. So I'd narrowed it down a bit, but not hugely. So I chose my rotations for F1 and F2 based on those interests. So my foundation programme, I spent first year in Hinchingbrook in Huntingdon, which is a small DTH. And I had the most beautiful job of all time, which was a supernumerary general paediatric rotation for 4 months on the paediatric ward, which I absolutely loved, but it was very well supported and I didn't have loads of responsibility. I then went off to do general medicine with geriatrics, which was a bit of a shock to the system with all the on-calls and the nights and the weekends and suddenly being the one responsible for the acutely unwell patient in front of you, and finished up the year with general surgery. And then my second year, I did a GP job, followed by paediatrics and obs and gynae. GP was hugely helpful for me because I realised that it really was not the place for me. Although I really like the idea of being a generalist and seeing patients of all ages and stages, actually when it came to it, I really needed time to think. I was very thorough and I worried about missing things. And the problem with general practice is that you see the whole haystack, but you need to be able to recognise the needle when it comes. And I think that's very difficult. So I realised that being a GP would be the worst move for me. So I discounted that from my list of careers. And so I decided to apply for paediatric run-through training in East Midlands North. And I made that decision for a number of reasons. I really enjoyed working with children. I thought I was quite good with them. And I enjoyed it a lot, interacting with children and their families. I didn't want to spend my life commuting over East Anglia because the area for paediatrics there is huge. And I had originally grown up in Nottingham, so I wanted to be somewhere where I had some local support network. So I applied and got a post. I started off doing my first year in general paediatrics, followed by neonatology. But I found this incredibly difficult. I think it was a combination of many factors. I had started dating somebody just as I left Cambridge to move to Nottingham, so I invested a lot in that relationship, which unfortunately broke down. I was studying for exams. I didn't have a great local support network apart from my parents. And then I found myself doing a neonatal intensive care job in a hospital where overnight the registrar was a 10-minute walk the other end of the hospital, looking after very unwell babies that I didn't feel really very skilled to look after. The induction wasn't great. It was a very tricky time, and actually I ended up getting very stressed and very anxious, and having some time off. And I think this was the point at which my perfectionism became quite apparent. And so I just wanted to kind of mention this because I think perfectionism is something that's pretty rife in medicine, and actually it's something that, you know, I found a challenge. And it is basically a personality trait characterized by somebody striving for flawlessness or perfection and setting very high performance standards, accompanied by overly critical self-evaluations and concerns regarding others' evaluations. And I think it's the setting very high standards, which either you meet but feel like you have to continually meet, or that you're not meeting and then beat yourself up for it. And so perfectionism is something I've always found a challenge, but this was something that kind of I masked that. And lots of my consultants who I was working with when I had this time off said, "Are you sure that paediatrics is really the right specialty for you?" And I thought, well, I'm not sure, but I'm gonna carry on. So I actually managed to come back to work, and I went less than full time, which actually made a big difference to me. And I also had some support from the professional and support system services, and they gave me some help on things like decision making in the face of uncertainty, resilience and time management, which were some of the things I was finding difficult. So then carried on with my paediatric training less than full time. I did a number of attachments in neurology and neurosurgery, intensive care, community paediatrics and neonatology. I completed my membership of the Royal College of Paediatrics and Child Health, and I completed my ST1 to 3. And my training program director was very encouraging and said, "Oh, I think if you want to do this, you can." But I was thinking, I'm not sure that my skill set and my preferences are really going to be best served by me continuing in paediatrics, where there are lots of acutely unwell children, and you again have to find that needle in the haystack. And I thought, I'm not sure that this is the right place for me. So I started doing some Googling, which obviously is a good place to start when you're doing research into your future career options, although probably attending a webinar is a better move. And I came up with a few options of things that at that point in time you could do from paediatric training. First one that came up was genetics. I thought, I'm not sure that genetics is the right one for me, although it's interesting. I don't really like reading papers about random genes, so that might not be the place for me. Community paediatrics, which I spent 6 months doing an attachment, and realised that while autism and ADHD are really important conditions, actually they weren't the ones that I was particularly interested in. So that was out. And then I found immunology, and I thought, oh, but I find the immune system really interesting. And that's what I did my dissertation on. And oh, this sounds great. So I went along to some clinics. So I actually contacted the immunologist in my centre where I was working in paediatrics and said, oh, could I possibly come to some clinics, please? And I also went to some study days, and I thought, this seems great. I think this might be the right place for me. However, at that point in time, the GMC no longer allowed people to do immunology from pediatrics. And it turned out the website I found was an old website. So I was slightly disappointed, but I thought, no, I'm going to see if there's a way that I could do immunology. So I communicated with various people in the immunology community and the GMC, and eventually they managed to change the system so that you could make applications into immunology from pediatrics. So I applied for a training post in East Midlands, and I then got one. And so I started 80% less than full time. I spent 2 years in Leicester, training there to begin with. But actually, I then again found it very difficult. It was a huge change going from working with pediatric patients to adults. I'd been out of adults for about 5 years, so some of the medicine had changed, and I felt slightly out of my depth. Immunology, when you first start, is a very different specialty from anything you've done before, and that was quite a culture shock, quite a steep learning curve. And I think to boot, my perfectionism also kind of weighed into this, and I again found it very difficult. And there were some local challenges as well due to one consultant leaving and there being one consultant who was manning the show. So I again got to a point of thinking, well, am I in the right place for me? Is medicine really the right place for me? Should I leave medicine altogether? However, I had some amazing input from occupational psychology, which actually was transformational in enabling me to carry on with medicine, and also to get me to a point where I wasn't worrying about my patients and missing things all the time, and enabled me to thrive. And I also had some input from occupational health. And at that point, I was also able to move to Nottingham to complete my training. So what did I want to be when I grew up? Well, eventually I figured out I probably wanted to be an immunologist, and I've made it to be a consultant. So I completed my training in Nottingham. I have really enjoyed it, and I've found that I'm not somebody who has done lots and lots of research. So as the other two immunologists who've spoken already, they've done quite a lot of research, but you don't have to do loads in order to do immunologist, which perhaps is not necessarily what you might think. But I have really enjoyed teaching, not probably to the same extent as Anne, but I've done quite a few bits in setting up teaching sessions for trainees and also some trainee revision groups. I passed my FRC path and I finished my training in June last year. So I've been a consultant for about a year. And this was some of my team members. When I finished my training, I had a party to celebrate. So we also have quite a lot of fun in immunology, as you can see from these pictures. So what do I do as an immunologist? So we've already heard a fair bit about what immunology entails. So in terms of my post, my role is divided into several sections. So I do some work in the clinical immunology area. So I do a monthly clinic where I see new patients and follow-up patients with a range of immune deficiencies. So as we've said, antibody deficiency is probably the most common immune deficiency. And so I see patients with recurrent infections and antibody deficiency. And I have a cohort of patients who are on antibody replacement or immunoglobulin replacement therapy who I see regularly. I also have a few patients with hereditary angioedema and periodic fever syndromes or autoinflammatory disease. I also get the privilege of doing some paediatric immunology as well, so I appreciate being able to do both adults and peds. So I do a twice monthly immunology clinic for peds patients, both new and follow-up patients. But I also have a role in terms of advice and liaison with GPs and paediatricians within the hospital and outside the hospital. We have regular MDTs in all of the areas that I'm involved in apart from the lab. And I've also been part of the SCID newborn screening pilot. So SCID is severe combined immune deficiency. And over the last few years, there's been a pilot programme running in about half of the UK where babies, when they have their blood spot done at about 5 to 7 days of age, they've been measuring T-cell receptor excision circles or TRECs on them. And those with low TRECs, that reflects there is likely to be a low number of T cells being produced in the thymus, and therefore those babies maybe are at higher risk of having SCID. And so we bring them in, we speak to the parents, we explain what that means, and we check their lymphocyte markers in order to establish whether they have SCID, because we know that the evidence is that if you have a baby with SCID and you can transplant them before they develop any infections or any organ damage, then the outlook is hugely much improved. So I've been part of that pilot as well, which has been interesting, and the data from that is coming through now. And then my post is that I'm employed by the laboratory side, and I'm part of the lab team. And as we've said already, the role of the medic within the laboratory is as a clinical role and looking at how test results impact on the clinical picture. I do a reporting session once a week where I will authorise and write helpful comments on the bottom of a variety of different immunology lab tests. And there's quite a strong component of clinical liaison where other specialty clinicians will ring you up and say, I've got a patient with this, could you do this test? Is there anything else we should do? What does this result mean in this context? Are there any other investigations you'd recommend? And as part of my lab role, I'm involved in implementing new immunology tests, some troubleshooting, quality work as well, making sure that as a laboratory we are providing a quality service to our users. And then the final part of my role is in drug allergy. So twice a month we see patients I see patients in the drug allergy challenge clinic, where we'll test and challenge patients to confirm or exclude drug allergy, usually by skin testing, intradermal testing, blood tests, and sometimes by direct challenge. If we think they're not going to be allergic, we like to exclude using a challenge. And the types of drugs that we often see are presumed penicillin allergy, perioperative anaphylaxis, and radiocontrast media and excipients, but that is not an exhaustive list. And just to finish, what do I like about being an immunologist? So I think it's fascinating and complex. The immune system is really just incredible, and the way that it works all together, and it's so synchronized and coordinated, yet targets a whole range of different components is amazing. And I like the fact that I have the basic science and the clinical aspect relates directly to that. I like the fact it's a significant team component, particularly when you've got complex patients and you will liaise with other people within your team and also in other centres and other specialties. I think it fits with my personality. I'm thorough and detailed, and it's definitely a thinking specialty. I'm an extroverted introvert, so I really like the balance of seeing patients in clinic, but also then going back to the lab and sitting with my computer and writing lots of results where I can remove the kind of emotive part of seeing my patients, because I'm removed from it, because I'm not seeing the patient directly. And I like the fact there's limited emergency management. The things you need to be able to manage are anaphylaxis, SCID, and infection, but there's always somebody that can come and help you if you've got somebody who's poorly. I really like the fact I get to see both children and adults, and I like the combination of specialising in one area of medicine, but inputting into the care of many patients with lots of different conditions through the lab. And the lack of out-of-hours work is definitely a bonus. So thank you very much. I'm sure there will be time for questions subsequently, but thank you.
Thank you so much, Betsy. That was a really good talk. So yeah, as we've said, if you've got any questions, please put them in the Q&A part of this Zoom and we'll go through them. So we'll just give people a couple of moments because I don't think there's anything in there at the moment. Okay, we've got some questions coming in now. So someone says, is there a chance to get into immunology from a medical science degree? So we've actually got a webinar coming up about that, and it's sort of immunology but aimed at science graduates. I think I'd assume if you want to be a clinician who's an immunologist, you'd have to do a medicine degree, but otherwise you can be a clinical scientist who does immunology. So we've got a webinar that the RC-Path and the University of Manchester Pathology Society are doing, and I think Rosie will remember the date for that. So Rosie's just going to answer that question in the chat. We've got another question, and it's, what is the most challenging aspect of being an immunologist/pathologist? So if you guys all just want to maybe each answer that question.
Sure, I'm happy to kick things off. Very interesting talks, by the way, both of you, well done. just to pick up on something that Betsy said, so that was a really, really useful insight into, well, making a decision in terms of your career anyway, but also into getting into immunology. So thank you for that. You did mention attention to detail. I think for me, I definitely have perfectionism in my blood as well. And I do very much enjoy immunology as a kind of thinking specialty, as you've both mentioned as well. But I think it does benefit from a degree of attention to detail. And it's sometimes a tricky balance to strike. Obviously, you want to give everybody the best possible care, but given the number of patients that we look after, especially in the long term, you have to think about striking that balance for that day, for that person. So that would be my suggestion in response to that. I don't know about the two of you.
So mine is probably a different answer, actually. My problem, I would say initially, immunology had such a low profile that, you didn't really have much of a voice in the hospital. And now that's kind of changed. And actually, immunology has a pretty decent profile. And now, actually, I'm too busy because people go, oh, let's just ask the immunologist this. And it's always some super complex case that you can't just look at it in 10 minutes and give them an answer. And as you said, you've got to think about it, and that takes time. So I think it's a good thing. People now want you and you're in demand, but it is complicated and it does take time, basically.
I think I would have to answer that question within the context of working as an immunologist in the NHS. And I think the NHS is quite a challenging place to work for anybody at the moment. And I think for me, juggling what Anne said about balancing kind of the amount of detail that you need to go in with the workload and with the burden and the amount that you have to deal with day to day. I think I think the workload is really one of the things I find most challenging. But I think the other thing is because of the workload, I think it sometimes can be quite tricky to stay up to date with everything that's going on, because there's so much happening in immunology, which is fantastic. But actually knowing everything that is going on, as well as doing your day job and coping with that workload, I think that's quite challenging.
Yeah, thank you guys. So the next question, well, firstly, they're thanking you all for the talks. They said it was super interesting and they really liked the insights. They're just wondering, as a medical student, how they can gain further insight into the specialty. So would they be able to shadow in a clinic in their holidays? So maybe if we just go answering the questions in the order of the speakers, or if anyone knows the answer to this.
Yeah, sure. I think the short answer is yes. I would suggest there's different ways you can go about it. So, for example, I think was it Betsy mentioned, going to a couple of sessions. I mentioned going to a couple of conferences. Speaking to people, I think, is quite useful, but it's often hard to know where they are, or at least that was my experience, given it was something that I wasn't, a specialty that I hadn't, been super familiar with up to that point. So, ask broadly, see if there's maybe a clinic in your hospital. If not, generally speaking, people are super supportive because we want, to nurture the next generation of immunologists. We know we're a small specialty. We know we've got to try a bit harder to get people to join. So generally speaking, even just, emailing people you don't necessarily know, has worked for me in the past. So yeah, try everything.
Yeah, so we have two affiliated medical schools here, and we've had med students from both the med schools approaching us saying, look, we're interested in immunology, can we come and spend some time in the clinic, in the lab? And we've actually now designed a combined, before people would just go to the clinic, and we now have a combined clinical laboratory elective that they can do in their fourth year, basically. So yeah, and usually immunologists are pretty friendly, so medical students just reach out to your nearest hospital where they have an immunology service, and I'm sure people would be very responsive. We're always keen for people to join our specialties, so yeah, we would open arms. We'd welcome people to come and just have a bit of experience.
And I would second everything that's been said already. I would say that when you're a medical student or when you're working, you don't have loads of time. So try and use the opportunities that you have as part of your course anyway. So it might be that you have a special study component or SSM or whatever they're called these days. Actually, if you can access some immunology clinics during that, it may be that you have to arrange it yourself and get in contact with the immunologist in your hospital, or in a hospital that you can find that's within your cohort of hospitals. But actually, that's a really good way of getting some experience. And it might be that there's an immunology related project or audit that you could get involved in, which would be useful both in helping you to understand a bit more about immunology, and also gives you those extra bits to put on your CV that show that you are interested in it. And I think what Anne's shown is that although you may have like what seems like quite an eclectic collection of things when you get to, when you get to applying, actually a lot of things that might seem quite generic, you can put an immunology spin on. But yeah, I think connecting with people in your hospital and exploring ways that you can do that. There are lots of things that you can do. We, as Anne said, we are all very friendly, and we love it when people are interested and engaged, and we'll find things for you to do if you want to come and join us to get more experience.
Thank you, guys. And then the next question is, will the specialty, or at least the immunodeficiency aspect, trend away from using functional assays and supportive treatment and move towards genetic testing and gene therapy?
Okay, you might need to revise what I say, but I think the answer is no. There is going to be, and there is already, a lot more gene testing and genome-wide testing. And we know we could be doing more, and we are trying to do more and increase access and increase equity between different patients to those kinds of tests, because they are super important and we appreciate the value. But actually, I think next generation sequencing is showing that it's not enough to know what the gene is, because actually interactions within our genomes are so much more nuanced and so much more complicated than we realized. And there are lots of tricky things that happen in our genomes, like pseudogenes and copy number variants and other things that can trip up our interpretation of test results. So I think that functional assays will remain a key part of immunology testing for some time to come. But I don't know what Betsy and Yousuf think of that.
Okay, so this could be a very long answer, but I'm going to keep it really brief. So basically, you two are too young to remember this, but in 2013, there was a debate at UK PIN, which said, this house believes that next generation sequencing will obviate the need for clinical immunologists. And everyone got very worried and thought, oh my God, when's our next payslip going to come from? And of course, 10, 11 years later, that's not what's happened, because you're quite right. Basically, even whole genome produces results that cannot be interpreted or are of dubious interpretation, like variants of uncertain significance. So we will need functional testing. And even now, 40% of cases of whole genome sequencing for suspected SCID doesn't reveal a diagnosis. So we definitely need that. I would say that the functional testing varies. So some functional testing can be done in clinical NHS labs, but other functional testing needs to be done in research labs. These very, very rare immune disorders, we can't have validated tests in clinical labs. So that work comes back to clinical labs in the future for validated functional testing. But that's where the immunologists are going to be involved in the validation of those tests, basically.
And I think I would echo what's already been said. I think what we found with next generation sequencing is that often we find a gene that is mutated in patients where we weren't necessarily expecting that to be the gene that was affected. So we've had quite a few cases where we've had older, patients who are kind of in their 20s who are identified as having mutations that should give them a severe combined immune deficiency phenotype. And I think the immune system is so complicated that although we expect that these genes are going to result in a very severe phenotype, we're actually finding that there are lots of changes that may be modified by other genes that we're not necessarily aware of, and therefore we don't necessarily get the phenotype that we're expecting. So I think certainly at the moment, functional testing is actually really important to help us to understand the consequences of mutations where the phenotype doesn't actually fit the genotype we're seeing. It may be that in the dim and distant future, when actually we've sequenced the whole genome, we know all about every variant of uncertain significance and it no longer has uncertain significance, and we can pull the results of all the different genes that we've looked at and all the different variants that we've seen in it, that we can predict what the phenotype will be and match it up to the phenotype. And I think in that situation, then we may not need functional testing, but there's a huge gap between now where we are and where that might be in the future. And therefore, I think certainly for the foreseeable future, I think functional testing in the whole context of the genotype and the phenotype is going to continue to be important. But I think, I think there will be a progress towards gene therapy for some things. But I think there are a lot more cases that are a bit more muddy and a bit more mixed where we're not there yet.
Great. So just the last question. Someone's just asking for recommendations as a medical student, what they can do to better equip themselves to being an immunologist. So just so we don't run over, maybe if you could all just very quickly give a short summary of recommendations or just one or two things that you'd recommend.
Okay, brief things I'd recommend. Reading is useful. Reading gives you an idea of the kinds of things that we see, and also an idea of whether that's something you enjoy doing, because being on the edge of, what's known a lot of the time, we do spend a lot of time reading papers. Maybe see if you can get involved in a project. You don't have to have a project at your level by any means. But again, it's kind of something to get your teeth stuck into. It doesn't have to be immunological per se. It could be something with an immunology slant, like we've said, renal or vasculitis, whatever it may be. But again, it will push you and see whether it's something you actually think you can spend your time doing. So that would be my 2 top tips.
I would say try and spend some time in an immunology center, even if it's a very short time, but to see what actually happens in the clinic or in the lab and just get that experience. And actually, when you're there, you can always say, do you have a little project or a little audit or anything that needs doing? And usually the consultants will have something that needs doing. So I would say get to a center and just spend a little bit of time there. And then that will give you an idea and keep your eyes open as to what it really is like there.
Absolutely agree with what's been said already. It's also, if you're planning to do immunology in the UK, then you will have to do some allergy within your training. So it is worth finding out a bit more about what allergy entails as well, and going to a clinic and speaking to some registrars in ACLI and ACI will be helpful. If you want to read something that that is interesting, and if you find this interesting, then probably immunology may well be the right place for you. And one of my favorite immunology books is called Case Studies in Immunology, a Clinical Companion by Rafe Geha, that's Geha, and Luigi Notarangelo. And it's that's just got lots of different immune deficiencies. There's a few pages on each one. And if you find that interesting, then probably immunology is a good place for you. The clinical handbook for immunology is useful, but I think in terms of immune deficiency, that's a lovely book.
Thank you so much. So that's the end of the questions. Just to end, we're going to do a short elevator pitch, and we're just going to hear from all of our speakers on why you should do immunology. So I think Anne's going to go first.
So my elevator pitch would be, if you like a mentally stimulating specialty that is not quite so full on with patients, gives you problem solving in the lab, and is more flexible with no on-calls, no evening or nights, then immunology might be for you.
So I was just going to show you the same video that I did 10 years ago, but just for this elevator, I'd say more complex cases where you can get your teeth stuck into, and you can go end to end. You can see the patient in the clinic, then go to the lab, interpret the test result, and then report the test back to yourself. So complete the whole circle. And as I said, every year we're getting new tests, new treatments. It's one of the specialties where, I can't think of another specialty in 10 years where we've advanced so much. And there's always opportunities for teaching and research. So it's complex, it's interesting, and it's advancing.
I actually just have a few shares that a few slides I'm just going to put up that I just put together. So if you like the immune system and the complexity and the fascination of this, of the immune system, which is so good at recognizing lots of different things, protecting you against infections, but also being controlled so that you don't get autoimmunity or breakdown of tolerance, and are interested in what happens when it doesn't quite go to plan. If you like things that are complex, if you're detailed and thorough, we see quite a lot of complex patients. If you like being part of a team who work well together, this is some of my team at various social events, not actually at work. If you like the fact that you get to be both in the lab and interacting with patients, and you get to have the kind of ability to see all the different test results and understand what those mean, and also the opportunity to connect with lots of other specialties through the lab and through clinical liaison, and have an impact not only on your own patients, but also on patients in other specialties and other parts of the hospital, then immunology is a great place to be.
Thank you so much, all of you. I'm just going to hand back over to Megan now.
Great. Thank you so much, everyone. Thank you, the speakers, for those really amazing talks. They're so fascinating. And thank you to all of your questions. We just have a couple of points before we let you go and get on with your evening. We're going to send you a short feedback survey by email. Please fill this out with your thoughts about this webinar, so that we can keep improving them and deliver the best webinars that we can for you. You can also watch our previous careers webinars on our YouTube channel, which is at I Love Pathology. We'll send this link to you by email, and we're also going to add the recording for this webinar onto that playlist in case you want to watch it back. So National Pathology Week, we're hosting it from the 4th to the 10th of November. There's going to be a number of online events that you might be interested in joining. So please have a look at our website for information on that. There'll be loads of interesting talks, loads of webinars. We'd love for you to get involved. And finally, you can learn more about pathology and about careers in pathology from our website, as well as our Instagram and our YouTube channel, as I mentioned before. So that's everything. Thank you so much, everyone, again. Thank you for all our speakers, for Rosie and Zainab for hosting, and for all of you for attending. If you do have any more questions, you can get in touch with us by email. But yeah, that's it. Enjoy your evening and good night.